Hello and welcome to another episode of Sharing Wisdom. I'm your host, Angie Wisdom, and today I am seriously probably more excited about this episode than I have ever been before about another one. I've got Dr. Gigi Kroll with me. Now, she is going to share some of the misconceptions, the concerns, all the stuff you hear out there about perimenopause, menopause, women's health. She's going to be sharing that with us. She's special to me because she's actually delivered my babies, my first one 20 years ago. So I have had this relationship with her from her being my baby doctor to now coming full circle and really focusing on that women's health element, which I think is so important because, gosh, we have so much misinformation out there. So Dr. Kroll, thanks for being here with me.
Yes, thank you so much for having me. I'm really excited about just speaking on these topics and educating women. And as you know, it's been my career for 25 years in private practice. Yeah. And so I've had my own evolution and understanding and having an opportunity to impart that. I'm excited to be here.
Yes. Well, and you know what? I heard you say something the other day on your social media, which I was like, man, that's powerful, because you said, I have to admit that I didn't really understand everything about what I was going through. And I thought, okay, I clearly don't, but man, if a doctor's saying that, like, it gives me goosebumps to think about it. So one, thanks for your vulnerability, but I think it really highlights how much information is out there for people to weed through. And if you as a doctor are having, like, it's a lot of work, clearly we are struggling on this end.
No, thank you. I wanted to put that out there, and partly to, like you said, be vulnerable, but to say, look, I am a expert in women's healthcare. As an OBGYN, I probably have, from a specialty standpoint, more training than any other specialty. Mm-hmm. And yet, even within that field, it's known that we get very little education during our residency. In fact, there's been studies looking at the lack of time that is dedicated to that, and that we really come out of residency not feeling very adequately trained to take care of this. Now you add on to the fact that the Women's Health Initiative study, and we'll talk about that more in a minute, really sidelined healthcare when it came to menopause. And if I'm somebody who is struggling, you think about all of the other specialties out there in terms of internal medicine, family practice, cardiologists, urogynecologists, people who take care of women's health. So not only is there education that needs to be done to the average woman, mm-hmm. but even in our physician community as well.
I bet. And we'll talk about this. We were talking about it before we jumped online, but like kind of the misdiagnosis. And that makes me think of, like, if other practitioners outside of this space don't even know, then they're chasing something different. So we'll talk more about that. Right. But, why do you think that is? Like, it's so interesting to me when you're talking about going through your residency and all the training and education. Like, why does the information stop at that point? Right. And it's like, well, what comes after that? The perimenopause, menopause, like, no big deal.
It's complex, but I'm going to try to break it down to the best that I understand it at this stage. First of all, I like to kind of state that back in 1850, which is really not that long ago, less than 200 years ago, the average lifespan for a woman was 39 years old.
Oh, wow.
Okay. So the idea of menopause is really relatively a new long-term health consequence. And in fact, our lifespan has increased really even much more rapidly since the advent of penicillin, which was in 1950. Okay. So if you think about that, we have a really short period of time historically where we've been able to get information. Number two, women were not included in studies or mandated to be included in studies until the 1970s. Much medical research didn't require women to be included, and they were done on men.
What?
When it came to heart health, absolutely. And so we really had very little federal money, private company interest in looking at long-term prevention and understanding the impact of menopause. And finally, we had a lot of fear come out of the one largest funded women's health study that everyone was very excited about in the late 1990s, but there's a lot of problems that came with that study called the Women's Health Initiative. And it ended up creating a lot of fear that really then stopped the whole train moving in the direction of us getting more information. That being said, I think there is, on a positive note, a big shift.
Yeah.
Actually, this government, the federal administration, just signed on for much more funding into women's health care, including in menopause care. Maria Shriver was big behind that, and there's a lot more individuals really saying this needs to be made a priority. So as much as it's a pretty dismal track record,
Yeah.
I'm optimistic about the future.
Yeah, well, that's exciting. I had no idea. Like, it's funny, you just don't research certain things, right? But when you say it from that perspective, like the life expectancy, the lack of research, even, you know, penicillin coming and kind of extending our life, like, that's wild. You say like 1970, and I'm thinking, okay, well, that's back when I was born, like 1974. So, like, my mom didn't even have kind of any of that knowledge and stuff, which kind of makes sense when you think about why doesn't information get passed on?
Right.
Like, her mother surely didn't have any information, and then
Right.
she didn't really have probably much to give me. So we're just kind of perpetuating this lack of information or misinformation, possibly.
Absolutely. And there was a stigma about it. There is also this kind of concept that it's the end of a woman's reproductive years, and therefore they were kind of not really that valued afterwards. And so people tended not to talk about it. And there's some stoicism, and you know, you'll hear kind of in some of the educators out there now smash the taboo. Let's not make this a taboo topic anymore.
Right.
And I think fortunately, with social media, with ways to access information, the up and coming generations are saying, hey, no, we want to live our best life. We want the information.
Right. It's interesting you say the up and coming generation. So are you seeing younger generations who are not even really at this point in their life going, give us the information?
Absolutely. Yeah, absolutely. I would say certainly women, when they're hitting their late 30s and early 40s, they're wanting answers. They're wanting to know. They're looking for it on their own. And I love that. I'm not the doctor that's, you know, some doctors will roll their eyes and the patient comes in and says, well, I found all these articles on the internet. I'm like, great, now we got a base.
Right.
And let's talk about how this is relevant to you, and let's add this. And because that's partnering with them, you know.
Yeah, that's key, because I've had doctors like that before. They're like, oh, yeah, stay off the internet.
Yeah.
Don't read, you know.
Yeah.
It's
And
like,
you don't want to go down a rabbit hole, but I also,
but it gives some context to start talking about.
Yeah.
Yeah, absolutely. So what are you finding? Like, when you started to go, talk about the symptoms, right? You started to experience your own symptoms that kind of led you down this path a little bit more. So for people listening, like, what are those symptoms?
Right. Okay. So I'm going to talk about perimenopause.
Okay.
And that's, you know, first of all, just the definitions really quickly, because I think that confuses people.
For sure.
Okay. So perimenopause we describe as the time leading up to menopause. And we realize now that's a 10 to 15 year period for people. And it's a time when the estrogen production decreases and becomes a bit more erratic. Okay.
Okay.
Menopause is defined as 12 months of no period.
Okay.
Now, that's an arbitrary diagnosis, probably came up by a man 50, 100 years ago.
Right.
But I say it's arbitrary. It still is our medical diagnosis, but many women either use an IUD or have an endometrial ablation, ways where they don't have periods anymore. And the reality is it's defined as when the ovaries really stop making estrogen, stop ovulating, and stop making progesterone. Okay. And you kind of run out of eggs, and that's it. That being said, once you hit menopause, you then become postmenopausal. And you are postmenopausal for the rest of your life. Okay. Or in menopause, you'll hear that same term. Okay. So you can see how the just verbiage can be confusing. Okay.
Absolutely.
So perimenopause, 10 to 15 years leading up to menopause, where you no longer are making estrogen at all. And then postmenopause, you're no longer making estrogen from that point on.
Yeah. Give me ages for those two. Like, I know they're not hardcore, but like typically.
No, good question.
Yeah.
So average age of menopause in the United States is 51 years old.
Okay.
Okay. And I always tell my patients, average, you think of a bell-shaped curve, average being in the middle. So you can be 45 and go through menopause and become menopausal. And you can be 55 and still be having periods. And that's all still within the normal range of things.
Okay.
Okay. On average, perimenopause then starts in the late 30s. And really now when I speak to my patients that are in their 40s, and even if they're having regular periods, I tell them, you are in the perimenopause decade, and let's educate about what that means and what you might experience as a result.
Yeah.
And then, of course, postmenopause, we address that. The tricky thing about all of this is that it's very individualized. There are some genetic factors. There are also factors based on an individual's own lifestyle habits. There's a completely different experience for everyone. And I'll use the analogy of when a woman starts her period. You know, we have the child who throws a tampon in and she's back on the soccer field, you know, and 2 minutes later.
Yeah.
And you've got the other girls who's home from school for a day in fetal position with her heating pad, you know?
Yeah.
And so there's just variety to how we all experience things. And with perimenopause, what we understand is that depending on who you read and look at, there's probably about 100 different symptoms that you can attribute to that.
Wow.
Which is quite a bit.
Who thinks about that? I mean, honestly, for me, when I was in my 30s, I would have not even thought that that was anywhere on the radar. Yes. Not at all. I mean, I'm 49 and I think I'm just now realizing that I might be in one of these phases with you.
That we might have more to talk about.
Can you tell me more about these symptoms?
Right.
But so I don't think it's on people's mind at that age at all.
Right.
And so these symptoms come up.
And you're not really knowing where they're coming from.
Right.
So, I mean, I can't list all 100
Sure.
now, but I'll kind of put it in a couple categories.
Yeah.
So the classic ones we hear of are the vasomotor symptoms. And specifically, you'll hear about hot flashes, or we like to call them hot flushes, or night sweats, or being warm at night. But there can also be other things related to that. We talk about mood changes. There can be irritability, more anxiety, more depressive feelings. You know, I liken the concept of the premenstrual timing where you have a drop in hormone, and that can trigger some mood changes. Or in the postpartum period, we have a very extensive drop in hormone, and that can be a trigger for mood changes. We look at cognitives. So you hear the term brain fog.
Yes.
And that's a big one, especially as we're in our 40s, we're at the top of our careers, we're, you know, CEOs of businesses, we're running a practice, we're writing books, those types of things. There's word finding difficulties, other things associated with just cognitive function that can be affected. Sleep disturbances that can go on. Musculoskeletal symptoms. There can be more joint pain and more aches. Frozen shoulder is actually a common symptom associated with perimenopause. And then there's the urogenital symptoms. So certainly our bladder, vaginal tissue, pain with intercourse, more dryness. And all these different things may evolve and only show up as dizziness or tinnitus.
Yes.
Or heart palpitations. And so a patient might experience a number of different symptoms and not relate them or have anybody string it together, that it can be due to this fluctuation and drop in their hormones.
So, I mean, that's got to cause, for me, when you said that earlier, I was like, oh my gosh, I went to the doctor for these heart palpitations. And he was like, well, take this pill. And when you have this and see, I don't even remember. It was a couple of years ago, but it was like we were zoned in. Let's do an EKG. Everything was related to my heart. Well, you're healthy. You should be okay. But take this pill. And if you start to really race, that's a sign that all this crazy stuff, right? So how many misdiagnoses are going on out there for symptoms that are happening early on?
And what I would say is, when you see a specialist who, like your cardiologist, went through and did the EKG and maybe a Holter monitor and maybe an echo, and what they've done is eliminate some of the other causes, such as AFib or things that
Right.
you really need to be taught, but really don't have a explanation for you or a even reassurance.
Yeah. They was like,
Yeah.
well, just everything looks good.
Yeah.
Maybe just relax a little bit more. Something. I'm like, I'm super relaxed, but to your
Right.
point, like maybe you get no diagnosis,
Yeah.
but are there people that all of a sudden it's like, oh, well, you're depressed. Well, let's put you on this medication.
Yes, so many patients get put on it, anti-anxiety or antidepressant. And I'm not saying there's something necessarily wrong with that
Sure.
treatment, but what I am saying is that knowledge is power.
Right.
You probably said that to you 20 years ago when I was seeing you. And I think it's really true, because when you don't understand something and you're being affected physically, it's frightening.
Yeah.
And yet when you can say, okay, this fits into a picture and there's an explanation and I can do these different lifestyle things to mitigate that, and work on the health habits and use these different tools, it's much more calming and less daunting.
Yeah.
Yeah.
So there's so much information out there now. Like, to your point, there was never enough information, and now it feels like there's so much.
Yeah.
And a lot of times the information out there is overwhelming or scary. Like I hear all the time about hormone replacement treatment or, different things that you can do for these symptoms, but then you hear horrible stories about them too. So how,
Where do you
what
go?
do you do? Yeah.
Where do you go? And that's the tricky part, is to vet your information and to have a really reliable source, and to be able to have them support where their information is coming from. So one of the things I tell my patients or start with is education's a big piece of it. There is an organization that's been around a while. It used to be called the North American Menopause Society. It's now called the Menopause Society, and that's within North America. There is actually an International Menopause Society as well, so you can get information. But think of it as a group of experts that are scientists, physicians, healthcare providers who really dig through the literature and try to boil it down and give their position statement recommendations, which will be very conservative, but they really are constantly evolving and regrouping them. They have a patient portal. They have a great website. They have a provider portal. So that's a good source. Within that, you can see who is menopause certified providers or members of the Menopause Society. And with that, they can kind of call themselves a menopause expert.
Gotcha.
Okay. And they're looking to try to find somebody that is within that realm.
Right.
And I think that's a good place to start.
Okay.
There's a concern, and it's kind of offside, that, if you think about 50% of the population, if they live long enough, will go through menopause.
Sure.
Okay. So, and if you look at women working and our ability to pay for things, it's being actually looked at right now as a large market. And when that happens, you actually do start to see things coming out, making a lot of claims.
Sure.
And playing on fears. So kind of to answer your point on that,
Yes.
I think that you have to be a very diligent advocate for yourself, and you have to look at what is being offered carefully.
Yeah.
And make sure that it's well studied.
Yeah,
Okay.
that's huge. I didn't even think about that aspect. Like, oh, this is another place for us to make money, right?
Yep.
For a
Big
lot
business.
of companies. Yeah. So do people start, I want to talk about the different treatments and what you believe, that the research that you've done and what you believe can be right for people. Does that start in that perimenopause stage? It does, that early.
Absolutely, yes. And again, it's individualized.
Yeah.
There are plenty of women in their 40s who are not experiencing any life-altering problems related to perimenopause. And it may largely be due to, again, good genetics, but the fact that they have adopted other lifestyle habits that improve their symptoms. We do know patients that exercise regularly will have less symptoms. We know if they have an anti-inflammatory diet. We know that if they get stress reduction and have good sleep, And, that's harder to do with all the electronic devices. And you really have to be conscious of learning about good sleep hygiene and making that a priority.
Right.
And getting into your deep sleep. So if you have somebody who is sailing through, great. If not, there's an opportunity for education and certainly an opportunity for treatments, hormonal and non-hormonal.
Okay. When you talk about the things that maybe are helping people sail through that a little bit smoother, does that have to be a part of their life before they actually hit it? So if somebody's out there listening and going, well, I've never been an exerciser, but shoot, I'll start now if this is going to help me. Is there that piece of it that like what you've built up until you've gotten there?
You are way ahead of the game if you've been doing that ahead of time. You're exactly right. I'm going to say it's never too late to start.
Yes.
So I don't want patients to get discouraged even if they've been in menopause for a few years.
Right.
But for instance, when we talk about the exercise piece, I think especially with the culture of just beauty in the world and modeling and so forth, it's kind of been about being thin. It's about being skinny, and what we're trying to kind of explain is actually you want to be strong. Okay, so going from cardio and not wanting to bulk up, now we realize, well, we actually start to lose muscle mass. And when we start losing muscle mass due to the drop in estrogen, and that is about, I don't want to quote it correctly, but I think it's about 3%, every couple of years. We then get ourselves at risk of something called sarcopenia. And that makes us more frail. And that actually decreases the amount of resistance on our bones. So when we are talking about how do we help offset it, well, if we build muscle, we are going to have a higher base level of metabolism. We're going to have stronger bones. We're going to be preventing disease, and we're still doing the exercise that's giving us the right mental health benefits too.
Right.
It's just changing and shifting what the focus is, a little more gentle, a little less inflammatory, which hardcore cardio can be, and more strengthening. So these are some of the things that we work on with
that resistance
with patients.
is important. Yeah. Well, it's funny because we've always heard that from kind of an osteoporosis standpoint, right? That we need that resistance, but it comes into play here too.
Yes.
So it's like, if you don't think that you're in this phase yet, and I think this is where it's hard because in the 30s we feel like,
you can bounce.
Untouchable. Yes.
Right.
It's like we often don't deal with problems until we have them.
Yeah.
But you're really setting people up to, at an earlier age, start these things now.
And understand them now, and understand them now. And then you're going to want to. It's just going to be kind of self-fulfilling on that regard. Yeah.
And so for the people who, I'm already in that and I'm coming to you now, and what do I do? First of all, I'm curious, is it important that you treat the symptoms? Because I know some people, maybe even me, right? It's like, well, I have the hot flash every once in a while, once or twice a month, I will wake up and I'm sweating. Like, you go through these symptoms, but you're like, whatever, no big deal.
Yeah, and that's fine.
Yeah.
You don't have to treat something that is not impacting your quality of life. Okay, so that's a great question. If it's like, I'm going to take my sweater off and it's not a big deal. But if it is impacting your quality of sleep, if it's upsetting when you're at a board meeting and you're going to turn bright red in front of a presentation with 20 people, then these are things that we can actually improve upon. Yeah, absolutely. I think that's probably the key takeaway, is that it's very individualized and focusing on what is impacting your quality of life and your ability to live your healthiest life. We can improve on that. And whether that does mean incorporating time with a therapist or a life coach, or getting a nutritionist or a meal delivery plan, or adding some hormones and working on how to control your bleeding pattern. And the weight thing is another big piece that a lot of women struggle with. How can we help with that? Because that's also then goes back into the overall health. Right, and lifespan.
Well, and I want to talk to you about the weight thing too, because that's big, right? There's a lot of things out there now that people are jumping on board with as far as weight loss. But question on kind of using hormones as a treatment. Is it a misconception that you should hold off on using them for as long as you can until you really, really need them. Like, does something happen where you need more of them, where you can never get off of them? You hear some of that language out there.
Gosh, good question. I think if it's okay, I'm going to go back to the Women's Health Initiative study.
Yes, please.
And just paint some broad strokes on that. So people our age may or may not have heard of the Women's Health Initiative study, but again, it was the study I alluded to earlier in the podcast that looked at women, and they were really hoping to show that it prevented cardiovascular disease, okay? And they put them on a hormone that was an oral hormone called Premarin and Provera, or Prempro, in one arm.
Remember hearing that,
okay?
yeah.
And the other arm was Premarin only. Well, Premarin comes from the urine of pregnant mares. That's where the name comes from. So it's conjugated estrogen from the urine of horses.
Wow.
Okay?
Okay.
And so it's not bioidentical in terms of what our ovaries make, but our body will break it down. The Provera is a synthetic progesterone that was manufactured and very different also than the micronized progesterone or the bioidentical progesterone we make. So that being said, those are the only two treatment arms, and they gave these hormones, these oral hormones, to women in their 50s, in their 60s, and in their 70s.
Oh.
Okay? So they were giving them to older women. And they didn't control for other risk factors such as obesity, hypertension, diabetes, and so forth. Long and the short of it, they stopped the study early because they claimed that it caused an increased risk of blood clot, stroke, and breast cancer.
Okay.
And it hit the news for some reason, like just went crazy with it, even before really all the researchers had a chance to break it down and look at the details of it. So everyone went off their hormone replacement therapy. They threw it in the trash, and all the women were afraid of getting breast cancer. Let's flash forward. Just recently, this past year, the WHI even had a paper come out saying that they overstated the risk of breast cancer. Okay. We also know that if you take oral estrogen, it does increase the blood clot risk, which then can lead to heart attack and stroke because it's the clotting of the arteries because it's metabolized through the liver. And in those cases, they were not bioidentical hormones. Since then, we've had many other studies looking at the estradiol, which is the bioidentical estrogen, and the micronized bioidentical progesterone, and using the estrogen in a way that it's absorbed through the skin as opposed to orally, although oral is still an absolutely valid option. And we actually have studies showing that estrogen alone reduces risk of breast cancer. In fact, there's quite a few of them.
Oh, wow.
And there was just a study that came out looking at 14 meta-analysis, and it was reduced. So to get back to your question of should we not use them?
Yeah.
Should we wait till the last possible minute? I think so much of that comes from old information, old data that has not, why we can't get this newer information in the news cycle the way that what WHI did.
It doesn't sell, you know?
Right, right, exactly. I think that's where, even physicians, again, if you're not a specialist like I am, you're not looking at that data. I can't keep up on the latest cardiovascular research. So I appreciate that.
Yeah.
It's hard. And so we need to really try to break the cycle of what's not safe, what is, and let that woman have a non-fear-based, honest conversation of what things can help her.
Yeah, that's huge. Because it's fear.
Yeah.
Yeah. And people have their own stories or their own experiences, which trickle down.
Right.
Right? Oh, when I took that, this is what happened to me, and
Right.
then they're like, okay, I'm out.
Right.
Yeah.
And yet we realize that women who are on estrogen kind of right after they go through menopause, it actually lowers the overall mortality by 2 to 3 years.
Wow.
And that they have a decreased risk of breast cancer. So we really need to look at that. One great resource I'll share was written by an oncologist, Avram Blooming, and his colleague, who's a PhD researcher, and it's called Estrogen Matters. And he was a oncologist at USC Medical School. I think his first edition was published in 2018, and he has a new edition coming out. But if you really want to break down the data and understand it, I think it's a fantastic resource, and I recommend that for people that really are stuck in the fear from the WHI and want to know the information.
Okay. We'll put some of that in the show notes too for people. To me, it seems like one of the things that people don't dig into enough. You know, they don't get the information. They don't research it. Why do you think that is?
I don't know, actually. But again, maybe not having enough good resources of where to go.
Yeah.
And where to find that information. So I think a little bit of one of my journeys is to try and help get that out there.
Yeah.
That's why I love doing this podcast with you today. I was excited for the invitation. There are a number of physicians, growing group, I think, in the United States that are really advocating for that. They kind of name themselves the Menoposse,
Oh,
which
really?
I thought was really cute.
Cute. Uh-huh.
And but advocating that the American College of OBGYN puts more of these kind of questions on our yearly board review so that it's being updated to the general OBGYN community, at least, you know, starting there and getting it into the residency education, and then getting it more on the public health radar. And like I said, I'm hopeful.
Yeah.
I'm hopeful.
It's interesting as we're sitting here and I ask you that question, I started to think about it myself, and it almost is like I feel like us having a period, us going through menopause, that kind of thing, it's just always been viewed as kind of like, it is what it is.
Yeah.
It's part of life. Deal with it. You know what I mean? It's not any trauma. It's not this thing you have to have treated. Like, I feel like that's the way we've just kind of been programmed. I've even known people who've had horrible menstrual cycles, right? And they're like, I can't believe I did this for 20 years before I went and got help. You know what I mean? And did something different. So I feel like that's part of the mentality. It's just, it comes with the territory.
Yeah. And I do think that needs to change too.
Yeah.
I do think that needs to change too. You know, women are really, we bear a lot of pain, you know, with our menstrual cycle, with the hormone change, with childbirth, with recovery from that, with lactation, and with menopause. And we do it maybe in ways that we could really actually decrease some of that suffering.
Yeah, we're tough.
If we had better education, we are tough.
We're really tough.
But, you know, do we have to always tough it out? Can we just do it a little kinder, gentler?
Yeah.
And when it looks at menopause too, same thing. Yeah, we're tough. And no, it's not a disease. It's a natural process. But if this natural process is impacting, let's think about our bladder. Now we have incontinence, and now we get more bladder infections. I mean, even just from a healthcare dollar, I think there was a study that said if postmenopausal women used vaginal estrogen, it would save Medicare millions, if not billions of dollars on urinary tract infections. You know,
Crazy.
There's just health things that could be improved, and that we don't always have to say, let's suffer.
Right. Just doesn't have to be part of it. Comes to the territory. Yeah. And I do think we are tough, and we talk all the time, right? Like, oh gosh, when our husband's sick or they could never bear a child, right? Like, we tend to just get through it. So I'm excited that you're changing that narrative, and you have been known as, you know, one of the best in our area here in Newport Beach and delivering. I run into people all the time whose babies you have delivered. And like I said, both of mine were delivered by you, but you're really evolving now, and you're shutting down that side of your practice.
Yes.
With a tear in your eye.
Yes. Yeah. What a privilege.
Yeah.
July will be my last month of delivering babies, and I'll have been 25 years in private practice in Newport Beach. And I get to take care of some of the young women that I delivered. I've mentored some of them in my office who are pre-med. And it just never gets old in terms of the miracle of that journey. But I also kind of shared that in understanding care. And I don't mean that in scheduling massages, but saying if we want to really invest in our own health and practice what we preach, which I think you do, like sleep becomes more important as you get older, and lack of sleep and kind of the cortisol changes and things, it actually really impacted my decision to say it's time that I really invest in my health that way. And that's kind of what dug into this whole process of me really trying to become an expert. And I kind of can't get enough now. Like, it's really fascinating, and I think it's really impactful to help other women feel empowered. And in this transition, just seeing my ability to help women, it might sound like a small thing, but vaginal dryness, not able to have sex with your husband, and now you're finally an empty nester and you have money and you can travel. And if I can bring that back and say, no, this can be fine, it's life-changing for them, you know?
Absolutely. I think it's just so neat how you've lived into the different areas of your practice for when they were, right? When I met you, you were having your kids too.
Yes.
Right? And you filled that role for so long, and I feel blessed that I was on the receiving end of that. But I'm so excited to now be on the new receiving end of your concierge practice, where now you're really zoning in on going, here's what is in my life and here's what's important, and where you want to bring that value to women.
Thank you for that. And I do look back and think, gosh, as a 35-year-old doctor, how did I help my 56-year-old patient? You know, I'm sure I could have done a better job in hindsight, you know, and I think that's part of all of us in our careers. We learn and we grow and we evolve and we become more seasoned. And I think that if your own experience can help you really see what you can bring to the table, without a doubt, it's that passion is there. And I definitely feel like that's where I'm supposed to be right now.
Yeah. And I can sense that. And that's why I wanted to have you on the podcast, because I was like, oh, she's just like, you know, oozing with all this information to share. And it's so well received and credible from you, which I think is important when you're talking about that information, and make sure you know where you're getting it from. I want to talk about your practice now and how you're helping people, but I also want to make sure we don't leave the menopause piece out. You talk about two different time zones, right? The perimenopause and the menopause. Is it much different? You know what I mean? Like, do people need to be, is it just different treatment? But does that make sense the way I'm asking that? I mean, I know they're called two different things, but...
So here's the good news. Okay, I always say that the perimenopause is actually when things get a little bit more chaotic.
Okay,
and it's, you don't kind of know what's coming, and maybe after a couple of years you're gonna have this other symptom, and it's like there's a lot going on in that change. And again, not for everybody, but that's when symptoms tend to be most profound. They've also looked at studies once you kind of develop those symptoms, and you hit menopause, now you're postmenopausal. Most things will settle down in about 7 years. Okay. And you hit kind of a new baseline. The brain fog tends to improve. You kind of hit where you're functioning a little bit more evenly, you know. Now, again, it's quite variable from person to person, but there is that kind of steady state that then develops.
Gotcha.
Okay. So that's something that's positive. And I would say that a lot of women, once they get through that transition and they're on the other side, you know, I really think a lot of women thrive. And I think that they are figuring out how to live their best lives. Now, that being said, the other education piece that I think is important is how not only do you deal with symptoms, but also how do you preserve your health. And again, it goes to things such as cardiovascular health, brain health. There's a great book out now called The Menopause Brain by another very interesting scientist, Lisa Mosconi, and she wrote The XX Brain as well. And she really describes the decrease in estrogen, or that it's a neuroendocrine phenomenon. You know, it's not just the ovaries, but it's the brain too. So trying to also kind of look at how do we prevent disease as we move into that you're more at risk for. And how do you improve your sexual function, bladder function. Make sure that you're maintaining your strength, that your bones are not developing osteoporosis, and so forth.
Yeah.
Not to mention skin and hair and all the other
Right.
things that go with that too.
Yeah, you just said a couple of keywords there, skin, hair. Well, I have to tell you, I'm over here smiling because when you started to say 7, I was hoping, I think, secretly in programming that you were going to say 7 months. So when you said 7 years, I was like, oh, dear God.
I'm all sit tight. Okay.
I'm like, wait a second, 7 years. All right, it's okay. It's only like 8% of my life. It's
Right.
okay. But,
Right. But we can thrive during that. And you
Yeah.
know what I'm also loving is seeing more public figures. I mean,
Yes.
Halle Berry, she's been a great advocate.
Yeah.
And looking at J-Lo,
Yeah.
looking at some of these women in their mid-50s who are saying, hey, let's talk about it.
Yeah.
Drew Barrymore, let's not find shame in it.
Right.
Let's show that you can live a good, healthy life, but
Yeah.
also let's demand more.
And
you
people
know?
are really changing their course. Like, do you know Tamsin Fidel? She's a news reporter. I was on one of her segments on TV before, and then all of a sudden it was like, I'm leaving that, and I am a menopause advocate. Like,
Love that.
all she does is she wrote a book. She
Yep.
puts information out all the time. Like it's impacting people so much what they're experiencing
Yeah.
and what they've probably like dealt with secretly and thought, I'm crazy. I'm crying all the time. I'm this, I'm that. And it's like, no, oh my gosh, this is happening.
No, you are normal.
Yeah.
And there are things that you can do to feel better.
Yeah. Amazing.
And us women are going to talk about it.
Yeah.
And again, there's some excellent male scientists too. So, but I think that it being something that we want to really get out there, drop the taboo, make it a conversation, educate, empower, and treat.
Yeah, that is why it is so amazing to have you in my corner and for everyone else that wants to tune into you. So now
Yeah.
your concierge practice.
Right. So this is something about 5 years ago. I transitioned into a concierge platform. We all know that medicine is really challenging right now, and physicians are having to see more and more patients with less and less time, and it really doesn't lean itself to great obstetrical relationships. I'm
Yeah.
not saying care. The docs do the best they can,
Sure.
but it's tough to have that relationship time. So this allows me to have same day, next day appointments, longer appointment time,
Yeah.
access 24/7 on weekends and holidays for emergencies.
Right.
But, of course, there's just things that when you have less volume and you can really tinker and get them patients feeling better much more effectively than a 15-minute appointment once a year, So that's been very satisfying. And I am practicing all of gynecology, including still doing outpatient surgeries.
Okay.
And I think that's helpful because, again, in perimenopause and menopause, there are some bleeding issues that can be a real challenge too. So trying to help patients navigate that and, again, really improve their quality of life, doing that is helpful. I also have launched a program called Get Slimly. And the idea behind that is helping patients with their weight management and from a medical weight management approach, looking at the whole person, understanding the genetic factors, the menopausal factors, the hormone factors, and using the whole tools from nutrition, exercise, behavioral modification, and medications as needed. I mean, I do want to emphasize that the GLP-1s, whole nother topic, but they
Translate
really,
that for me.
Sure. It's the glucagon like peptides.
Okay.
Which are, you're more familiar with hearing the word Ozempic.
I was gonna say
and
Ozempic.
Wegovy.
Gotcha.
And then now more currently Mounjaro and Zepbound.
Yes. Okay.
They really have some incredible potential to help change the narrative for people. And we're seeing their indications growing, including cardiovascular disease prevention and beyond type 2 diabetes. And even in patients that might not hit those large kind of definitions that the insurance company wants, it can greatly improve their fatty liver, their blood pressure, their risk of heart disease. It goes on, arthritis, and so forth. So it's a health approach.
Yeah.
Again, it's trying to make sure it's the FDA-approved medications and tinkering with how that can be given in ways outside of the standard once a week, and trying to figure out what works best for the patient. And it goes a little hand in hand with the perimenopause, menopause journey too, for patients. And it certainly is a way to help in that transition as well.
It sounds like you get to be such this hands-on, like preventative, proactive,
Yes.
right? Wellness.
Yes.
But then when you run into something, I've got you there too.
Yes.
Right? It's not just reactive, it's very proactive, but sometimes things happen.
I think you hit it on the head. And I think this is, I think now 25 years in private practice, you look back, and allopathic medicine has always been a little bit criticized for the fact that it's treat the disease rather than prevent the disease. And I think that is still the case too much. And I think now we understand there's a lot of tools to say that there's prevention is going to be so much more effective.
Right.
And we can make that happen. And so I'm embracing that for care of patients now.
It's so important.
Yeah.
I mean, I think, and I feel like people in the medical profession are so annoyed when they hear people not in the medical profession like me going, you know, we treat the symptoms and it's just medication. I know there's a time and place, I'm sure, but for the most part, being able to treat the person proactively and preventatively is everything.
It is, absolutely. And that's what the younger generations excites me too, because they seem to take a bit more of an interest.
Right.
They have more knowledge on nutrition than we did.
Yeah.
They have more knowledge about exercise than we did. They're looking at what they're putting in their bodies. I mean, not everybody, but I think there is an access to that information.
For sure.
And I get excited about that ability for them to really learn and embrace that.
Yeah,
So,
it's true. It's interesting as you say that. I think about, yes, some are more discerning about like, what are we putting in and what are we being fed, which is huge.
Yeah.
I just got, God, is it Good Energy? I shouldn't even say it right now, by Callie Means. I just got this new book, and it's all about, you know, the food and like how it affects our body. I know you're getting into that too.
Yeah.
So it's funny, we have kind of a new generation who I think is being more in tune to that.
Yes.
But yet that's a whole nother subject.
Right.
What they're consuming emotionally and mentally from like social media, it's a different world too.
Right.
But I know the nutrition aspect is huge too, which I think there's so much preventative work
Absolutely.
to be done there too.
There is. And like I said, it's never too late to start. So that's the good news. And I think that we do have good data to show that.
Yeah.
So changing habits now can go along in the future.
It's exciting. I mean, this is like, not that I'm having you on this podcast to go, everybody reach out to Dr. Kroll, but like, I want people to take away this message that you should be seeing a doctor, whoever it may be in your area. If you're here, maybe Dr. Kroll, like preventatively, to go, what should I be doing? Yeah. How should I be treating myself so that I don't have to come see you for a problem later?
Absolutely.
It's just different now.
Yeah, there is even a specialty called lifestyle medicine, and that's a newer specialty, which is really trying to promote that and saying, okay, live a healthy lifestyle. You know, let's take all of these different things, and you know, listen. Life is busy. It is hard. There are stresses, but there are things that are in our control that maybe we don't really put as much priority on as we could or should. And so if you understand, like I said, knowledge is power, then it helps motivate you to do that too.
Absolutely.
Yeah.
And it's part of like what society grooms us for, right? I mean, we've always been taught that you go to the doctor when something is wrong.
Right.
You go get medicine, you go get treatment. And so we weren't ever really brought into this medical space of like, well, you should know ahead of time, you should be preventative care. So it's kind of changing that narrative too, I think, for people, and seeing it differently.
Absolutely.
Yeah.
Absolutely. Osteoporosis, we'll take that really quickly. And it is the thinning of the bones, which starts to decline in women after age 30 and then drops drastically once they stop making estrogen. Okay. Estrogen does help prevent bone loss. There are some other medications that can be used. Medicare doesn't recommend getting a bone density scan until you're 65. by that time you have osteoporosis.
It's too late. Yeah.
Right?
Right.
And again, we have to look at healthcare dollars, and I understand that. But I also think, again, if you have an idea of where you are, you're going to just be able to be so much more effective, right?
Absolutely.
And help in preventing getting to that point. Because once you have a hip fracture, and you have that frailty, the loss of life within a year of that is about 25%.
Wow.
Yeah.
That's insane.
Right.
Yeah.
So,
And the fact that you start losing bone density at 30, like where, maybe I don't know. I try to stay off of the internet and consume too much information, but
Sure.
I feel again at that age, you don't even think about that.
Not at all.
You
really don't.
No. Yeah. I want to kind of drill you on a couple of quick takeaways for people, because I know they're like, some of these questions that we all want answers to. Supplements. Anything that you love that I know it's probably really hard for you to recommend something.
Yeah, well, I'm not going to go brand, but there are a couple things.
Yep.
I honestly think one of the things I've seen be the biggest game changers in my population is vitamin D.
Okay.
Okay. We are in here. We are not in the sun right now. I'm in my office. I'm in the hospital. And even though my dermatologist probably would yell at me about being out a little bit, we just don't get enough vitamin D.
Okay.
So for women, I do recommend between 2,000 to 5,000 international units a day.
Okay.
And that's going to be one of the biggest things they can do to prevent bone loss. But it's also really important in terms of our immunity, our mood, and another 30 functions. Okay. But the bone density piece is huge. Okay?
Love it.
Yeah. So vitamin D. I'm a fan of magnesium. Again, we need more research on it, but here's the deal. You can't really overdo it. It's one of those that you will excrete. We have fat-soluble vitamins that will hang on to, so you don't want to overdo it on D because of that. But magnesium has been shown to help with over 300 different processes in our body.
Wow. And
it can help with sleep and restless leg syndrome, which certainly can be an issue associated with perimenopause.
Okay.
Fiber. I just think we don't get quite enough fiber.
Through food or supplement?
Ideally through food, but if you can't or you don't, then supplement is a good way to go. Okay.
Yep.
And there's a lot of data still out a bit on the omega-3 fatty acids, but I do think if you don't eat fish or some high source of food with omega-3s, supplementing with that is probably going to have some brain protective effect, and certainly joints too.
Love it.
Those are my big ones that I would say. I'm sure we could talk about a whole thing on this.
Oh my gosh. I know it's hard. It's really hard. I have to refrain from going, what about this?
Yeah.
Exactly. So we can go down this rabbit hole.
We definitely can.
Number one or two misconceptions around anything that we're talking about, either health and wellness, supplements, perimenopause, menopause, anything.
That estrogen is dangerous.
Okay.
And that you shouldn't take hormone replacement or hormone therapy because it's going to put you at risk of disease. I think it's a big misconception. I actually think that it will help prevent disease, and I do think that there's a lot of data to support that.
Oh, good. Perfect. What about food?
In terms of misconceptions on food?
Or just any, what would you steer people away from, or what would you say they absolutely, you said fiber.
Yeah.
But some people are like, oh, you shouldn't have dairy, you should eat less meat. My primary care is you should really be as green and as non-meat as possible, all sorts of information.
All sorts. Okay, I'm going to make it very clear.
Okay.
Avoid highly processed foods.
That's easy.
Right? Your refined sugars,
yep.
your your oils that are going to. There were Twinkies and Ding Dongs when I was growing up. I don't even want to know what's in that.
I was raised on those.
Right.
Ho-Hos, little Debbies.
Yes.
Oh, yeah.
Avoid processed food.
Okay.
Okay. Eat whole food. As much as you can. Cook a bit more, or if you don't know what's in the food that you're getting, and I think we have great choices now, in that regard as well. So I'm just going to keep it at that.
Perfect. That is good advice and something that people can strive for. Yes, 100%. Okay. Yeah. Any magic tidbits that we're leaving out here? We talked about obviously all the big stuff, but you also gave us some supplements. You gave us some food stuff. You gave us some misconceptions. Anything else that you're dying to tell us?
Yeah. I will say that skin and hair, we talked that's
please.
A big thing. And I would say that's super important. If I look back now, obviously I would have worn sunblock a lot more. you know? But I think that one of the nice things is there's more and more tools out there for women to feel good, you know, about kind of their aging. There are experts with topicals, certainly your retinol. Some people are even beginning to use some topical estrogen. We need more studies on that. Your different serums, hyaluronic acid and vitamin C. And I think, again, women feeling good sometimes goes along with them feeling like they're looking good, you know, and if they wanted to, you know, dab into Botox, that's okay. You know, these are all things that I think help us feel good about that. So finding also a dermatologist who is somewhat educated in menopause as well. I think is not a bad idea.
You want to throw a name out there? You're like, no, I do not.
I know too many that I like that are all good, but I would say it's certainly something to ask. You know what I mean? And a lot of it they'll say is preventive too. You know, so.
I like how you just like, I'm just going to say that. Just ask your dermatologist if they know much about that. Got it.
Exactly. And working with a dermatologist. And again, there's a lot of supplements people will sell for hair, for skin, and, you know, some may be beneficial, but it's also just work with a healthcare provider is what I would advise. There's so much
of that out there.
Yeah.
I mean,
that's why I want to advise that.
Choke down 4 Nutrifoils, I'd do it, but I just can't.
No.
I just can't do it.
Exactly.
You mentioned kind of Botox, and I know I'm holding you forever, but we're going to wrap up here. The Botox aspect, some of the fillers and stuff. Do we know enough?
Great question. I think we can say we know enough about Botox. Okay. Botox, you know, if it got actually into your serum and went to other parts of your body, we'd be in trouble, right? Because it's a paralytic agent. But it basically breaks down locally over time. And there doesn't seem to be a cumulative added effect. It's been around, we've been using it cosmetically for several decades now, and we're actually using it for a lot of other things. We actually use it in overactive bladder. People who have a twitchy bladder and they'll actually have incontinence, they'll use that for. We'll use it for muscle pain, do injections in muscle spasm, migraine headaches. So increased perspiration. People have certain diseases that cause that. So I think you can feel really comfortable with that. And in it, by just decreasing some of the lines, it helps decrease the etching on the lines. And, you know, for some people, it just helps even with that headache there. And especially as our eye and visions change, you know, it can help decrease some of the kind of headaches that you can get from squinting and things too. Fillers we don't know as much about, you know, and so I think it's an individual thing. I'm going to just say we know less.
It's a gamble. It's a crapshoot. I mean, do what you want.
Not my area of expertise.
Yes, perfect. This has been so amazing. I know that everyone listening is probably so grateful for all this information that you have shared. Where can you have a couple Instagram accounts?
Yes.
So share some information. Where is it best for them to follow you, learn more about your practice, and just get all this helpful information? Because you're putting that out all the time.
Thank you. Yes, I'm really enjoying. I started really talking on my Instagram during COVID because I knew my patients were hearing me. They were hearing my voice. And so all the content on there is me. And for good or bad. Not the highest tech.
It's all been good.
But it's at Dr. Gigi Kroll. Gigikroll. And then with Get Slimly, because it's a bit more towards our nutrition, exercise-based information, and talking about that, it's literally at getslimly.com. And there's also a getslimly.com website.
Okay, perfect. And we'll put all that in the show notes, but follow her. I mean,
thank you.
It's hard to find people on Instagram who are giving good information that are very genuine and authentic.
Appreciate that.
Yeah. So I super, super appreciate that. You feel like you're listening to a real person who is living it, who cares. So thank you for showing up that way.
Thank you so much, Angie. Appreciate you.
Thank you for being here today.
I loved it.
Thanks.